Welcome, we're going to get started. So today, obviously, we're going to see what the Motion Lab is all about. And we're excited to have you here. We'll hope you'll spread the word to your friends and classmates that it's here and it's available for you. Mike Lawrence runs the lab, and he's going to do a demonstration with his lovely assistant. And then we're going to break into interprofessional groups and have some conversation about a couple of cases that would pertain to what happens in the Motion Lab. And then we'll come back together and report out about your results on the cases and have any further discussion you wish to have. So, without further ado,
Hi, if you can't see the screen, at some point it'll probably help if you can see the screen. I'm going to just give you a quick kind of background of what actually is going on here in fairly simple terms. We have 8 false office cameras hanging up around the room. These things you see sticking out of the ceiling here. And I know no one can see where they're sitting, but this camera actually has a clear screen. If you want to take a look, you can actually see behind the lens, see how it puts out what it does. It's basically emitting right now infrared light. That's a light that we cannot see, or else you'd feel like you're like in an easy bake oven to be surrounded by red lights the whole time. There's another camera system that does that, and I'm so glad we don't have that one. So that infrared light comes out, floods the room, and anything reflective will reflect that light back to the cameras. So we use these little reflective markers right here to reflect that light back to the camera. If you guys can see, you can see the screen out over here. See that little point moving around? It might be hard to see over there, right? So the light's coming back. This is a view from each camera, so it's seeing a reflection of this marker right now.
we want to give everybody an opportunity to shift,
Sure.
since the focus will be on that for the moment.
So can you guys see that now? That moving around? There's also something else reflective. I think it's your backpack in the corner back there. Just turn around. So like athletic clothing, those reflective things on there, pretty much does the same thing. So if we have people with athletic clothing or shoes come in, we have to like tape up their shoes, tape up their shorts, whatever it has on them. These are actually made with some really expensive tape. It has crushed glass in it. But I'll pass that one around and see kind of how shiny it actually is. Then, well, each camera, I'll use a short term, easy term, fancy math happens. And we'll hit click 3D. And then you get a 3D rendering of the motion of these markers. So all the information from all 8 cameras comes together. I said fancy math happens, and this is what we get. So we can tell the position of all these markers in space now. Go ahead and come out here. So what we do is we put these markers all over a person. Do it on 3D. And this is obviously a live shot with just a little bit of delay, a couple of milliseconds delay. And we can now measure Danny's motion wherever she goes in our capture volume. You also notice those little arrows coming up out of the floor. We have 3 AMTI force plates sunk into the floor here. And the idea of that, think of it like your bathroom scale on steroids type of thing. So if you just stand on one of them, okay, stand normally on one of them. The height of that arrow, if I go in, I can actually pull a number from that. That will tell me how much she weighs. Okay, so it's like a bathroom scale. We can use it to weigh people. But the other thing it does is measure not only up and down, it measures side to side. So you see how the arrow's moving? And diagonal there. And then front to back. So we get the measurements, you know, up and down, how much force are you going directly into the ground, how much force are you using to push off or break yourself, and basically are you leaning to like the left or right side when you walk, or do really whatever. So we get the information from how she's moving with the markers, put it to like specific points. Then we get the information from how much force she's generating into the ground from the force plates. We use something called inverse dynamics after that to calculate up the joints to determine the joint reaction forces and the torques required in the joints to cause for movement. So we have those two things working together. The other piece of hardware that we have is electromyography. You guys familiar at all with electromyography? EMG? Okay, a little bit maybe. It measures muscle activation. So you remember back to your basic exercise physiology course, you need an electrical signal to go to the muscle to cause contraction, right? So we have these sensors here, and it's actually measuring that electrical signal. So go ahead and go like 90 degrees. Right there. Relax. So notice if she's relaxed right here, we get like a resting rate right there. Flex. Hard. Hard. Relax. Right. Wait for it to go around again. Go. Relax. Go. Relax. Okay. I also have one on her calf. Yeah. On your right calf. We had like some 10-year-olds in here doing a project the other day, and they just played at the force place for about 10-15 minutes. I didn't even show them the EMG for that. So now we can get the forces, their interaction with the force between the ground, where she is in space. We use that to calculate the forces at the joints. And then we use the EMG to calculate how the muscles are causing those forces. So it's a really comprehensive and complicated picture when you get all the way done with it. And it can be a kind of intimidating gate report when you get done with the whole thing. So what you guys are seeing right now is completely unprocessed live data. Are you twitching?
Yes.
Okay. These little spikes? Yeah. I'm going to pull up some data. So the next step would be is we would take this in here and label it and do some processing and basically attach a skeleton to it. And the skeleton is a representation of each individual person. So the size of the person is determined by where we put the markers on the person. So it's really unique to everyone that comes in. If they have any an issue with cerebral palsy, we'll pick that up. It's really obvious when they're standing. If they're really valgus or varus, their knee position. If they have a hip hike, it's really easy to pick up. And then we attach that skeleton to the motion. And get something that looks like this. That's pretty slow though. And let's see if I can pull up this little show force. And here's something that's called a force butterfly. We can see how this person was applying force to the ground over time. And this is what the software used then to do all of our calculations. Literally, we can calculate thousands, if not millions, of things from this data. So it's kind of important to know what you want to look at, or have some reasoning at what you want to look at. A typical report will come out to look something like this for a gait analysis. And this is something we'll go over with the DPT students right now. So I'm sure you guys look at this and be like, yep, bunch of lines and graphs. Okay, right? You familiar with what an angle is? Right? It's like a knee angle, flexed or extended. Okay, so an angle just tells you where you are in space, your position, right? One segment's relative position to another. So that tells us where the person is. That's in the very left-hand column. It goes hip, knee, and ankle. So your hip, your knee, your ankle there. The red would be this person's affected side. This person actually has torn their ACL and had it reconstructed. So they're about 6 months after surgery at this point. The hip moment. You guys remember way back to physics what torque is? A little bit. It's the rotationary force at the joint. So we move, our joints move by rotating, right? Almost, especially lower body joints, most joints of the body rotate. So it's these forces that we use to combat the ground. And you really want to combat the ground because if you lose against the ground, you fall on your face or your butt or wherever you go, however you lean. So to combat the ground, we create these joint moments. So hip moment, knee moment, and ankle moment. Something really indicative of someone who has torn their ACL is they don't like to generate much of a knee moment. You see the difference there between the red and blue line? That means that person is basically trying not to use that knee to generate force. What they typically do is they shift it to their ankle or their hip. They shift away from it. And they also tend to typically move it a little bit differently. See how this red line kind of clips off earlier? So they tend to walk really stiff. Start really stiff and try not to use their knee to create any force. The third column here gets a little even more complicated. It's about generating, producing and absorbing energy at the joint. So we'll steer clear of that one a little bit. That takes a little bit longer to explain. So basically this report, when we look at this, because see how we might put someone through an intervention, we see their knee is really stiff, they're not moving it very well, not going through the full range of motion. You'd see that they're trying to avoid using their knee extensors here. It's just a knee extension moment. So really, for some reason, their overall torque there is decreased, their knee extension torque. So either they have a weak quad, or their hamstrings are coming on, firing way too hard, pulling them back. People with ACL injuries, typically it's the hamstrings coming on more, because if you have your quad come on and your hamstrings come on, it really secures the joint. And it tries to make it really stiff. Which you can see from their knee angle, that's how they're walking, really stiff. Because the body wants to protect the joint from unnecessary movement, avoid re-injury, right? So it stiffens up the joint and kind of locks it down a little bit while they're walking. Some of the stuff you could see if you're watching them, I know PTs, physical therapists, they could probably know if someone's walking with a stiff knee. What they can't see is how are they handling the forces inside their joints, or how is their muscle activity different or similar between the sides. So we're like the next step for a gait analysis. We don't just do gait analysis in here though. We do approach any movement you could do in this area, aside from golf because the ceilings are too low, and swimming because the basement would have to flood. That already happened once in the last year, and it was not a good day. A couple of the other studies we're working on. This one's actually mine. I like to do resistance training stuff. So the person here is squatting up and down with 60% of their max weight with what I call an unstable load. So I suspend the weight with elastic bands to make the bar really shaky. And I'm trying to figure out if that caused them to use like more abdominal muscles or more lower back muscles. So I'm using the EMG to get the muscle activity. To figure out if they're generating more muscular force. So you guys have any questions yet about any of this? I completely missing everything and leaving you all behind, or you kind of following it?
If you were looking at the unaffected side, do you see changes to compensate? So with the ACL you're talking
With the ACL you can actually. And they'll actually see, sometimes they'll see the unaffected hip compensating. It depends. You can divide people who turn their ACLs in a couple different groups. Some people go right back to sport and they're just fine. Other people, they can't really ever get back to that same level. And so they'll compensate using the affected leg, the unaffected leg. There's a variety of different methods they'll use.
Have you used this at all with people who are amputees and, to evaluate the effectiveness of the prosthetic?
Yes, that's something we've actually kind of piloted and started to look at a little bit.
Yeah.
She just walked by. Katie. Dr. Rudolph. We had a question about amputees, using this for amputees.
Yeah. Could you say a little bit how that's used to evaluate the effectiveness of the prosthetic device?
Yeah, so we can determine whether the movement pattern, for example, prosthetic feet, there's a lot of different designs of prosthetic feet, and so we can have a person walk across the force platform and see how much push-off a particular prosthetic foot gives them, and sort of validate whether they need something like that or not. There are some prosthetic feet that an amputee has to get their limb into a certain position in order to take advantage of that, and so if they can't do that, then it doesn't really justify the cost of these kinds of fancy prosthetic devices. So this can help with that. And it can also help to identify, what are the major gait deviations that are happening and give you an idea of what you want to treat. In that case, it's if the person can't extend their hip enough, then you need to work on hip range of motion in order to get into that position, and then work on the gait training beyond that.
Thank you.
Sure.
Is this something that insurance pays for? If so, what's the patients?
it's always kind of a fight, yeah.
Insurance doesn't.
Yeah.
That's a major barrier to this kind of technology. So the main population that uses this data from a lab like this is pediatric orthopedics. And that's for kids with cerebral palsy, because they need this kind of information in order to make decisions about surgeries. So you would do a study looking at their walking patterns and when the muscles turn on and off. And if the muscles are using a particular pattern, then we know that a certain surgery will be helpful for them. And if that pattern isn't there, then we are not going to do that surgery because that's not going to help them. But even with those cases, a lot of times what the labs do, labs in pediatric hospitals are often part of the whole system. And so they might, charge for gait analysis, which, doesn't even cover probably the supplies that you need for a lab like this. So it's a big challenge, and so.
It kind of is what it is.
How many labs are like this in Maine? Is the only one?
Yeah.
No,
Well, they're creating one. They're not up and running yet, so.
No, they are.
They are?
There's 2 up in Orno, which I just found out about a week
There's
or so
another
ago.
one.
Yeah. They're not used clinically, but they exist up there at UNE.
So this couldn't then eventually be bundled into like physical therapy services could it? For billing
That's usually what people
purposes?
do to try to get some reimbursement.
Uh-huh.
Yeah. So usually, like if it's a clinical assessment, usually they do a clinical evaluation first, so they measure strength, range of motion, those kind of things. So they can charge for that. And then they can charge for the gait analysis and any kind of consultation. But the gait analysis is the same kind of gait analysis that you would do visually,
Okay.
so.
So could they do, you have any PT program or any PT clinics that refer patients here for?
We haven't so far. I mean, we just relocated up here, so that may increase. But again, I think it's the biggest challenge is the cost, and we have to cover our costs here as well, so we sort of have to pass on some of the cost to outside folks, and so it's challenging.
So it's primarily for research at this point, is that right? Is that
Research and teaching. A lot of teaching activities, and we really love talking to people about trying to get some activities in here for teaching. And if there are clinical examples of things that people want to bring in here and use in their classes, we love that. And we're trying to sort of develop a repository of teaching materials. So one of the things that everybody seems to need in health professions is ergonomics, And so we can have some objective data that show, this lifting technique is putting this much stress on your back more than another lifting technique, and maybe the objective data will help people really remember that. So we can collect data from one person, but it serves 5 programs, so that's what we're looking for.
It's mostly pharmacy students, I'm guessing?
Mm-hmm.
Okay, so something like similar is people actually move differently and walk differently when they're in pain. So if you want to test, the effects of a drug, of a pain drug, to see if that, I got rid of the pain, but got rid of some, bad movement pattern they had, that's something that this lab could do.
And it's actually a great tool for looking at the effect of medications. So like Parkinson's medications, things that help with the motor control and limiting tremor and things like that, we can, test it at an optimal time after they've taken a dose of it.
Are there different patterns, EMG patterns for different types of tremors? So if you were having difficulty differentiating a patient's tremor, are there different patterns?
I don't know that much about tremor, looking at tremor with EMG, but it seems, whatever the kind of, what would be the two
Thinking
different
like a
kinds?
tension tremor versus a Parkinson's tremor.
Yeah, so we
there's-
could certainly do that, because you could have the person, collect some data at rest, and then collect while they're doing something.
Mhm.
And then you could document what the pattern was, both through the motion, but also through the EMG patterns, the bursts of activity. Sure.
I'm wondering about a clinical referral. So I have a patient that has bilateral ACL tears, and he's had one surgically repaired that failed, and he's wondering whether to go through the whole surgery
Yeah,
process again or just live with it. So is that an appropriate referral? Like, could you help him make
Well,
that decision?
I'm not sure. So there are some studies that show that certain landing patterns from a drop jump are indicative of a risk of injury. Risk of re-injury is a different story. It may be the same, we don't really know.
Right.
But I don't know that the gait data would tell you whether they would benefit from the surgery or not. I would think that that would be based more on their symptoms and, you know, do they feel unstable when they're walking? And they can tell us that a lot better than a gait study would. And I say that because I'm really interested in knee instability. And what happens when people are unstable is that they co-contract their muscles a lot. So we could document that, but we don't know if that's helping them or hurting them. You know what I mean? So in that sense, the gait data wouldn't help. We could say that they're not using the normal range of motion, or that the body isn't, you know, counteracting the loads on the knee as it should. But as far as what does that mean, you know, not sure. And so, but see, this is the kind of thing that it would be very interesting to have a case like that on our files that we could use clinically. And, you know, maybe there's some interesting differences in their symmetry. And that's an unusual case too, so.
Do you know how they tore their ACLs?
Skiing.
Skiing? That's a tough one. You can't really do skiing stuff in here. Sometimes, like, if people they have really bad landing mechanics, we can definitely pick that up and, you know, say, well, this, not necessarily this caused it, but this is definitely a bad way to land that could, you know, cause a re-injury or cause injury. At least, you know, when you land like this is never a good thing. So it'll tell you kind of what they might need to do. But instead, skiing is, there's a lot of different things involved in the skiing. So you could hit a branch and just accidentally, or you have a good movement pattern and still tear your ACL.
But again, those are, you know, and if anybody from pharmacy is working with patients and, you know, looking at different effects of medications, we would love to get them in here and document those things, because that's helpful for everybody. And it's just, you know, seeing the difference in a dose of medication for Parkinson's patients really, I don't know, it sticks in my mind better as opposed to just saying, well, the tremor will be reduced. Well, how much? For how long? We would love to add that kind of patient to our repository.
I would think even the most common, the low back strain, where probably your EMG would show spasm or the increased muscular activity, and then just looking at anti-inflammatory medications, because that's, some people use steroids to see if there's actually much of a difference in
Yeah. That would be
we
interesting.
think that
Yeah.
there is, but
Yeah.
yeah, understand.
Anything else to demonstrate or explain? I think
Well,
people
explain.
want to see Danny move around some more on the screen.
What is this?
What is this technology called? Like, does that have a name? It might just be the question.
As a whole,
Yeah.
probably emotion analysis is the best term for it.
Okay.
And it just kind of breaks down from there.
Okay.
Yeah. Emotion analysis is probably.
More from occupational therapy.
Oh.
Just gonna throw that out there. Ooh, don't forget about that.
Mike, I'm interested in the modalities we're using for healing. So for example, watching someone in yoga positions
Mhm.
and seeing how that flows and how it affects. Because I think we make an assumption that yoga works well for every, you know, it's like everybody, but I'm just, it'd be interesting to look at some of the healing techniques that are out there. Why don't you get into a yoga position there?
Let me take an idea of, you know, where I am, where my markers are, where we're gonna, you know, start small, little child's pose business.
How's she doing there?
Right, down to the dog. So,
Yeah, good for you.
sliding around a lot. Danger.
Yeah.
What do we learn?
What are we learning? What are we learning here, Mike?
Well, if I had both your feet on the force plate, one thing we could look at is where that center of pressure,
All very
I need yoga test now.
is where that center of pressure is moving
Yeah.
relative to her foot. Because we know once that center of pressure gets close to the edge of the foot or goes outside the foot, you will fall over. So someone who has good control would keep it fairly centralized.
Well, and this is the kind of thing you could be looking at how she performs the movements, but then you could also look at just regular functional activities before and after doing a session of yoga.
I mean, I'm really thinking about, not having it as a one-size-fits-all recommendation, because for some people it's
Yeah.
fabulous. For other people, it may be harmful.
Yeah.
For people who need to do some more intervention in their musculature or joints, who might be going into positions that would be, aggravating them more than healing them.
And that kind of study could be looking at a clinical exam of their core strength, their, upper and lower extremity screen and range of motion, those kinds of things. And then see, can they get into those positions, and then you can. So yeah, those are all possibilities, it's just a matter of getting it to
Even how the muscle activity changes over time.
Yeah.
If you have someone who's brand new to yoga and they get in like the warrior pose or something and have balance issues, 6 months later, they don't have the balance issues, has their activation pattern changed at all?
I have a question. So this looks at muscles, but if you use it for something like assessing fall risk, like osteoporosis.
Well, fall risk, there are,
Like look at the elderly and seeing their gaits, how they walk, and maybe assess if they have a higher chance of falling into the.
yeah, so this is a great example of, we have tests of fall risk based on just functional tests, like the bird balance scale, the timed up and go, things like that that are very clinically relevant and you don't need a lab like this to do it in. But there's a lot of work being done on fall risk and sort of looking at muscle activation and quickness of muscle activation, things like that, that we don't really know what the data mean yet, and so, there are some things that are known, this isn't my area, but that, if somebody's muscles aren't coming on quickly enough, then we can sort of try to decide, well, why is that? Do they have a peripheral neuropathy? Do they have, decreased proprioception or whatever? But to really use or to really investigate something like that, you have to have a way to induce a fall in a safe way. And so, like some labs will have a track that goes down the middle and you can put a harness on it, and then they have the person walk, and they actually has, one lab has something that pops up and it sort of prevents their leg from swinging through, so it's inducing a fall. There are treadmills that are designed that you can put perturbations into them so that the treadmill is going at its regular speed and then it stops for a second and then it keeps going. So you're trying to challenge them and see, okay, how are you responding to this? Are your muscle activations quick enough? Are you detecting it? Things like that. So, but it's not really a clinical test. It's more of an investigative test in that case.
I see it being great for research and like you can gather lots of data or something.
Absolutely, yeah. And then you take the data and you relate it back to the clinical tests and you say, well, is this clinical test really good enough? Is it really capturing what we need to capture to predict that? So yeah. And then you get to the point where you don't need the lab data anymore. Now you have a new clinical test that you can do. It's the UNE balance test,
Am I right in assuming that these labs can be for athletes? Like if you had a situation like this with a really long plate, could athletes be using this kind of thing to see how
This
they
is
perform?
this is actually a pretty big area for a lab like this. They first started off about like a hallway. So we've grown a lot. We actually have this size because Dr. Hardigan does do research with athletes, so we need the size for them to be able to run and get up to speed and slow down. I believe it probably first started just looking at gait issues. Am I correct with that?
Yeah, I mean, I'm
Yeah,
not
something.
sure what population sort of it started with, but certainly athletic performance is huge. I mean, but clinically, I think really it's the pediatric orthopedics with kids with CP that has the biggest and most established sort of group of labs.
Seems like we could use it to track jaw motion if you were to put things on the face or individual fingers.
Yeah.
Could you do that in a place this size, once you're on the plate, because it doesn't matter?
What we can do, I have gone down to fingers, it gets really complicated, but they have done that.
Yeah.
They have actually done someone playing a cello. But it depends on what you want to look at. You could get really, really small markers, put them on the face. We probably have to reposition our cameras to get right up on them to do that. But jaw motion we could probably do, I think, fairly easily with this current setup we have, depending on what we wanted to look at, size of motions and all that.
The cello is interesting because there's a whole area of healthcare that's about taking care of musicians and actors and dancers and stuff like that. And all of them suffer repetitive motion of some kind eventually, and to be able to see it coming and head it off if they have something like this to track their motion.
Yeah.
Well, that's the kind of thing that if you have, let's say you have a cellist come in and you have them play for an hour, you can look at their movement patterns throughout that period and see, is it because of fatigue that they're getting into bad positions, or is it just a bad position to begin with, so yeah, those are absolutely the kind of things that we do. And that gives the person an idea of what they need to work on.
It makes it interesting for me because I watch a lot of people walk, but definitely want to put the cello down here again.
Yeah. And we can use the EMG system without the motion capture system too, so we can take that out and collect data without the computer in here. So it's pretty versatile.
So that's portable then? You can take that out of this class?
Yeah.
So, does anybody have any more motion questions, any more demonstration to be done before we move to the case discussion?
Last time I did a cartwheel in Navigators, you had that of me in there, and you see my legs go up and fall over. I thought I could still do one. It's too slippery. I'll die.
No?
But you did ballet, so there we go.
It's almost like others.
Just being able to deal with the slipperiness of those force plates was quite impressive.
Seems like a challenge.
So we're wondering what professional groups are here. We have OT, pre-OT, and pharmacy. What?
I'm nursing.
Nursing. Pharmacy. Okay. What we'd love to do is get you in a couple of groups, as Chris said at the outset, and we have a couple of cases that might help to construct that we'd like you to look at together. Think about the information you've gathered from Mike, which was very wonderful. Thank you so much. And just have a conversation about them. There are a couple of questions in each, and then we'll come back as a group and utilizing the knowledge you've gained and utilizing the knowledge you bring to the situation. We'll talk about cases together. There are 2 cases, and we'll distribute them.
Well, I think one of the OT ladies will come down here, and some pharmacists will go over there. We'll be mixed enough. Maybe PA faculty or PCs can pick a group. each other, exchange names.
Drawing here.
Might get a see what it is. So do you want to say more about the kind of conversation?
I just wanted to see if that was a suitable
Oh,
thing.
yeah.
We just love you to talk about the case and think about, when you read the material, does it make sense and what more do you need to know? And what do each of you bring into the conversation about which case? Case number one. What other information might we need to really take advantage of the services here and what it would bring to helping this particular patient? So, and you might want to just introduce yourselves to each other so that because some of you know each other, some of you don't. So that'd be great. And what your field is, and we're going to bring another person over here in a minute.
Are you on?
Alyssa.
I tried it. I found it. Yeah.
I injure myself thinking analysis.
Yeah, I was just curious, I know
Make sure to introduce yourself. I'm Diana, PA.
It's not just the line, it's all connected together. So it should only require a certain muscle to do the motion, but they can't control that.
Yeah, I guess the phrasing to see is like the non-involved.
Yeah, that's
How could a non-involved have the whole?
right.
Any questions on them? There's a lot of weird stuff on there.
All I'm trying to do is the quadriceps there's a deficiency in that, like the hamstrings are overcompensating. Is that what's happening?
Yeah, I remember I said something like, sometimes with people with ACLs, like their quadriceps will either be weaker, or they'll have the hamstrings like compensating for it to try to stiffen the knee. So that way to protect the joint a little bit.
Is that just because of like the lack of motion for like recovery and surgery? That the hamstrings begin?
Usually the other way around is the hamstrings will cause a lack of motion. So while you're trying to extend, I think the hamstrings like activate more and more and actually pulling back. They might even have like passive range of motion, but when they try to dynamically do a task, it's like it keeps coming on and trying to protect the joint, try to suck it back in.
So you're saying like that since there's an ACL here, they lost the integrity of the joint, so it's real loose. So what the musculature is doing is contracting to protect it and keep it from moving because the ACL is.
Yeah, even if the ACL is repaired and the integrity is like structurally there, they still tend to show that pattern.
Because it was doing it for so long.
It doesn't even have to like really happen that long. It's just like that's what their nervous system starts doing. Yeah, and we get some people who come in here even like 4 months after surgery. I don't have to see the scar on their leg. I can just tell because their quadriceps and leg looks so atrophied. You can tell which knee they
And did you say that he would have or they would have better passive range of motion?
They could have the same passive range of motion like the normal leg to the.
But then when trying to do it actively.
Yeah, they might never get, or they'll be really stiff. Actually, they tend to lose strength, like in range strength, like the last 15 degrees of extension.
So does it, in terms of like physical therapist stuff, like do they tell them, teach them how to do so like give them like a minor feedback.
Lesions don't get worse, although.
That's part of it, that some people do.
And their muscles and bones
They apparently don't do that as much here in May. It's more based on like a timeline. They're like 5 months you're clear to go back to sport,
So for
unless your knee
example,
still
if they're in
hurts.
a wheelchair allowed, they may have to
A lot of other places, they have to go through like a battery of strength tests and hop tests and functional tests to be able to go back. And this is their
large range
pretty
of motion.
free with them.
I mean, I'd hate to give them medication or anything, but, you know, like even nausea and vomiting, they tell us it's a learned response. If you don't pre-medicate before you go under and you're given opiates or whatever meds when you're going under anesthesia, if you don't pre-medicate and they get sick, well, the next time, every time they're gonna get sick, because it's a pre-learned response. So I wonder if if you can somehow do the neurochemical test while you're doing the muscle test to see what's really going on.
I have no idea how to do neurochemical
Yeah.
tests, but let's do
Me
it.
either. I know they do it.
So my question to you guys, I think, is how does this report, or how do these deficits impact this person's life currently?
And so,
Do you see any
and they're measuring a lot of
issues
different
with
muscles, I'm not sure.
what he does and perhaps how his deficits
But
impact?
you can see that there's parts of activities and whereas,
It's on his right leg, so
he is the
using his driving,
So
yeah.
this is a study that's part of.
So would you want him driving you around town with this?
And she's looking at,
So that's a
sort of,
potential.
when you're doing activity with one
I mean,
hand,
that could
what
impact
kind
his
of
livelihood.
muscle activity is evident in the other side.
Okay,
Without
that's
onset diabetes,
answers my
which
question.
is
Yeah.
assumed
Yeah.
So
that is
C
related, but
depicts the
it probably
non-working
is, and
hand
that's
of
adding more
the
stress.
cerebral palsy child when the other hand is.
What else do you know
Okay,
about
got it.
Exactly.
Diabetes.
And you can see that, you know,
That's something
normally,
that
if you're just
driving
using
a
one
car.
hand, the other hand can relax.
Yeah.
And
But
this
that's
child
not the
is
case.
Interesting to see if there's a, if he has
And so,
neuropathy and he's
part of
trying
her
to
research is looking
know
at
if he's on the gas or the brake or that type of thing.
help them learn
So,
how to keep them.
those are, when I read the cases, the first thing
And
I think
essentially
about
what
is,
she's doing
how
is
is this
trying
impacting
to
the patient?
help the
And
person
we as
learn how to
providers
separate
know that, well, we
those
want
two
to
things.
correct this and this and this to make him perfect, but what's important
This
to
is,
him?
so
For his
the
day-to-day
C
activities,
is
it
the
may not be
activity
exactly what we have in mind.
in the, so this would be a
To know
a child
what
with
he needs in order to
spastic
function.
hemiparesis. So C would be
So, do you think that he'd
the
be,
person, the child.
looking at his background,
squeezing
how
with
would you
their-
explain
they're not involved in
this
so the one
gait
with
analysis to
motor
him? I
control.
mean, he's just
And
a,
then D is,
he's
is
just
the
a
other
driver,
hand
right?
that's
Does he
supposed to be
understand
resting. And it's in all of the muscles.
I think that's where I was comfortable, and then,
Yeah.
With cerebral palsy, you're not going to have it all over.
So it's his
Kinda-
background.
It's kind of tricky.
He's an engineer, he has an engineering degree, right, even though he's a chauffeur.
And this really,
So,
we think of it as one of them.
how would you explain
But
this to
really,
me then, that one of the questions
It
is,
does have,
if you, how could you
Physics
explain it to
equations.
him? That's right. He understands it better than I do. So how would you explain this to him and?
Do you see the differences? I mean,
so
Probably
A
no
and C are a
subflexion,
little bit
extension
different, except that,
movements.
Probably understands the
I
concept of a
think
moment or a torque
what would be better is to look at the,
issue.
how do A and B.
And then why is it important for
compared
him
C
to
and
work
D?
on improving
So A
this?
and B, A shows
What would you
them
tell him?
live doing the activity, and B shows.
Or be safe
them
driving.
is life.
And what might make it not safe for him to drive?
Whereas
Which
when
of his
the, when
activities
the
then?
uninvolved limb C is active,
What's he need to be
D
able to
can't
do?
relax. D is
Showing
showing
flex it,
I understand that it's, she can't hide her.
get in and out of the car. He's a chauffeur, he's getting out, he's opening
No.
doors.
Because the A and B are
Carrying
active
bags.
So D is showing much more activity than C.
Yeah, and I think the more you do it without correcting it, the more it's going to, the hamstrings going to keep getting stronger. And then quadriceps going to keep.
So D is showing much more activity than C.
And then, of course, that's going to keep.
So D is showing much more activity than C.
And then quadriceps going to keep
doing things together and trying to.
Or there's pain involved, like for using this, doing it wrong, doing it wrong. There's pain involved, then you can get rid of the pain and then like teach them how to do it properly.
And I think that that's exactly
Make it
right,
easier
and I
for
think
them to do it
the
correctly.
goal of this research.
So how are you gonna know, once you control the pain and you teach him to do it properly, how are you gonna know that he's doing it properly?
While they're grasping.
Come back and do the test.
There's another project.
There you go.
My only worry about that, I'm sorry, I'm sitting back here. My only, is the question that, I don't, one of you, I think, raised is how's he gonna pay for this? You know, and that, you know, so how would you translate this from a great application to being used in his clinical situation? I mean, I wonder in 5 years, 10 years, this might not be just what you do and it's paid for by insurance. I mean, when MRIs first came out and other, you know, advanced medical technology, it wasn't paid for. It's like, that's cuckoo, like craziness. That's just experimental. And I think probably soon, maybe 5 to 10 years, will be part of the treatment process and evaluation process.
There's actually, I know a doctor who's working from a grad school, did a lot of work to get the cerebral palsy. And he refused to cut them until he had data analysis done. And then after they had the surgery and recovered, they would do another one to basically see were we successful and what else might have come
More
through.
muscles are showing this, what we would call it basic activity, so burst of activity. And then
Well, another thing too is the MRIs and the CAT scans, they give you a picture, but they don't show you function.
And that's so much on the magnitude.
This is much more practical in terms of the actual function and were you successful? You might see that things were repaired, but what's the difference if the function hasn't?
Yeah, that's what I've been trying to figure
It
out.
looks better, is it actually better for the patient?
Well, so I guess from our standpoint, we'd also be looking at what's going on, like her mom is.
Yeah, it can be really variable.
And the mother, so.
If you were to go to a hospital and order an analysis, like just walk in and say, I want a gait analysis with a full EMG, you might be talking about a couple $1,000s. Most of, one of the things I think that will help is we're getting better at processing the data. What you guys saw, like the skeleton and all that, some of that has been automated now. Obviously, I still have to check it to make sure the computer did it right. But used to be you had to go through every frame and click on every single marker. So what used to take weeks back there, I can do minutes now. Back in the early 90s.
Sometimes spasticity is so great that you can't get problem.
Yeah. Before that, they actually did it, they didn't do this, but they did it on overhead projectors. So they project the overhead onto a chalkboard, draw it out, do the equations by hand, go over to the next frame, draw it out, do the equations by hand. So I'm glad I missed that part.
You know, the other thing that's extremely amazing about this and cool is that people will come to clinicians and say, I still have my pain, it's not going away. And sometimes a clinician will say, well, it should be gone by now. I don't understand why that's still happening. I'm sorry, I'll move over here now because I guess I can. And now you can see it. I mean, you know, you can actually not have a level of assumption that you've had in medicine and clinical practice. There's a way to verify, oh, you know, you have an unusual port.
Yeah, you're compensating somehow for a gait pattern.
Right, and it's so individualized that for you healing from an injury, let's say, it would happen a very different way. For me, my pain may persist, and yet the average person shouldn't have that pain anymore. So people jump to the middle of the bell curve. So it's really, it's very, I think it's extremely exciting to see it in action.
The other exciting thing they're starting to do with this stuff is simulations. There's some actually free software out there now. It's just really complex. I've tried dabbling with it. You can take someone who is just, say, walking, collect a normal gait trial of them walking, let's say they were a construction worker and they had to carry, sacks of concrete, 50-pound sacks, you can actually then load the model up and apply that 50 pounds to the model and see what would happen if they were to do that. It will calculate the forces, joint reaction forces, and see if they're more
Some kids with CP, they'll.
likely to develop bad patterns.
To weaken the muscle, and I'm not sure how, when I have
1 o'clock now.
I'm not sure if that's still as popular as it is.
I work in the OR
The other
for
folks that are-
Yeah.
there'd be a day where they do like 12 kids.
Yeah.
So they still do.
Yeah,
that,
all right,
yeah.
so
I know it's a lot
I'll
of
go back
lower
to
than.
5.
Yeah.
And
Deciding
all
what to
stressing.
do.
So I'm just curious how OTs would think about using this, service, this assessment tool.
Well, I don't know. I kind of thought just initially, especially because you talked about like how they're going to pay for it, insurance and stuff like that. So I thought initially you use it more for research and like justifying like these exercises support this motion.
One of the ways we
And,
might use that like this is to say.
it's kind of like creating it more evidence-based rather than using it in the clinic, because then you can take that evidence and bring it back to the clinic and be like, this is why this works. And kind of
Where do we
prove to your patients and
how far?
other
Insurance
companies,
companies.
insurance companies, stuff like that. So I thought initially that was the idea when I saw that.
But like, what does local?
Also ergonomics.
Centimeter.
Actually see.
No, so they would have to sort of keep putting the.
So have you come here yet for
So
the
they do
classes?
No.
So another thing would be to maybe advocate.
Yeah,
we're
that's
definitely
what
gonna tell the track on.
Yeah, definitely. This would have been really cool.
Yeah.
Because she said like integrate it into your research classes. And we had no idea that this was there.
I'm
So
not sure.
That actually started the PT department. We have several actually almost case-like study things. Bringing someone with Parkinson's, and he's swearing that he has a device he puts in his mouth, a mouthpiece, and it makes his tremors go away and makes him function better.
Physicians are thinking, well.
So we're actually going to take some measures in here to see how he responds. It's more of a, they're going to do some clinical tests as well, but this will actually give us some concrete numbers.
Yeah, they do worse motion analysis.
You may have something there.
He might, he might. What about pharmacy? Will see this maybe integrated into your,
They have little mini
your practices and how could you benefit?
The motion analysis system really is cool.
Yeah.
That would.
I don't know if you ever hear about it, it's just talking about like the learn response.
Oh, yeah, I did hear that, yeah.
Yeah. They do have systems.
But I mean, research is the first thing.
It's really the
that
system that's working. But yeah, they have some recording
for insurance to prove it's working. For Parkinson's stuff.
See like how drugs
It varies. Sometimes there are no cognitive
might respond to the drug.
disabilities at all, and sometimes they're.
Because
I
we
have
could
a
just,
family member who has Parkinson's, so this seems very promising. Because I don't want her to be on meds for the rest of her life, and then because it comes with side effects, so if you can avoid taking meds, it's better.
And the pain, the pain medication,
Yes.
to see how it is helping to people to stop compensating or overcompensating to,
Yeah.
because people don't even realize how much they're compensating in their bodies for pain, that it has become so much a part of their life that they don't even realize that their beta's off or they're, and they're exacerbating, let's say, their foot because they're compensating for their gait, and then they end up with back pain and foot pain and lower back pain. And so I think,
That can depend on.
having some ability
It kind of depends, like some
try
kids, they
some
come
pain
in with
medications,
Botox
and again, not wanting people to live on them forever,
They
but
really
to
relax
see
with
how
it,
they can help people
procedure,
build up
or
the
they
muscles that are
freaking out. And that can be
weakening
kind of the
or
mental
maybe we can see
overcompensating.
if their movement patterns are even caused by pain, because they might have pain, but they still might have that underlying movement pattern
Right.
there no matter what. That might be retrained.
I see a huge for insurance coverage for some of these modalities. As a family practice person, if you want to refer a patient to PT or OT and their insurance only covers 3 visits, what are our choices then? Well, our choices are giving pain meds so that they're not living in pain, or try muscle relaxants or something like that. But
So an
That's
interesting
covering
thing is, and I don't know if you guys.
the underlying issue. So I think the research to show insurance companies that in the long run, if you correct some of these
And,
things,
you know,
in the long run, you're gonna be saving surgeries and
Discussion, because
rehab
somebody's
centers
got a lot of
and all that
ideas.
type of thing.
Do you try to do something that will just somehow externally
So what do you find
control her
participants?
extreme movements,
Where we
or?
can.
therefore-
We can pull from, for the ACL
Well,
studies, we
I
can
mean,
pull from a
yeah,
local
like
doctor's
waiting, that would
office,
be a good example.
orthopedic
As opposed
associates.
to
I deal more with, healthy college age students because they're plentiful around here. I'm trying to pick them up wherever I can.
How much time does that
But
take?
I think you should introduce it.
looking for someone who's a specific condition, we'll go to a doctor's office and recommend to the study to get some, get their patients in here. Hopefully that will help recommend people to come in and get some.
That might be beneficial for a learner.
Well, if the patients think that it's something you
all the time and want you to do on your own.
I bring this up because a couple of years ago, we had a.
Oh,
Discussion, and the amount of practice one needs to
And really,
do to get neuroplasticity.
Stacey, that's what I've been doing like the past 2 weeks really in depth right now, that's what's on my mind. We do also the strength measures on that torture looking device over there, the chair.
You want a
biotics.
person in the clinic 8 hours a day for 6 months.
We do strength measures there, so I talk about like the quad deficiency.
Interacting and, you know, socializing.
We're finding that
There's no answer,
here
there's no
there's
answer,
up to
right?
40%
Right.
deficits from one leg to the other. So and they're being cleared to go back to, like soccer or field hockey or whatever. Those people are the ones you can look at and say, that leg is smaller than that leg.
Stuff that kind of helps some more PT, but it makes it more of a game.
Large deficit.
Like the repetitive, like you
Well,
said,
would
there's
that be
exercises
a
when so
long-term
many times
effect,
that
like
really
if
it's
someone
hard
is
to
a
get
young
those
athlete is
chronic
functioning at a deficit, is that going to be overall impact their, adult and older adult
engaging the
health?
brain, other things, just
Yeah.
especially since she's
Especially with
Yeah.
definitely some osteoarthritis.
Yeah.
Some of those issues there.
Yeah,
I think if you have like a occipital contraction,
it improves.
so if you have a joint, if this is your femur, and this is your tibia, so if you have contraction on both sides, you're in essence pulling it together harder. Now you've got more force between the joints, it's going to cause more wear and down on the cartilage.
So you're saying that after they have surgery, you're still seeing contraction of the hamstring and quad, and it doesn't go away with time. You have to retrain.
It's weird, some people, they get it and then it goes away. Some people, it's like they get it and they can't ever get rid of it.
You have to train them to.
Train them, even sometimes through training, some people still can't get it. They've tried that, they're trying that now. Actually, they're trying things like perturbation training, just to try to retrain. So you put them on a platform that moves to try to retrain their sense of movement there. I like the chemical response.
And it's amazing, if you immobilize a person, it's amazing how quickly you lose muscle mass and strength.
Standard procedure here is to immobilize for at least 1 to 2 weeks.
It's amazing how quick you lose it.
Especially as you get older. I could be a geriatric.
I think we could probably get a group of faculty in here if you want to.
Yeah, maybe should be a subject.
Do you do the athletes here?
Done
See if you could get them before, and then if they have any
Yeah.
injuries during the season.
There's a guy out in Ohio that does that knee reflex. I mean, they have all the local high schools, so they've collected 5,000-6,000 athletes over the years. Because those studies are really hard, they're really good, but they're really hard because it's like, if you collect 1,000 people, how many get injured this year, injured we're looking for.
And you're in the sidelines celebrating when someone gets injured.
Yeah.
Long, like.
So we're gonna just try to pull these two groups together and share some thoughts and.
Yeah.
You should just
Hey, the
converge if you want. IPE doesn't mean that everybody's in the same place at the same time, but it helps. Oh, they do.
Well, really, I was thinking about it. I had ACL surgery, having some bottles, so it's kind of like. Yeah.
small group amongst this group.
Sure.
Let's hear you guys we have representatives of one group here and one group here, so.
Does everybody know each other? We have, who's our nursing student?
That's me.
Yeah.
Sorry.
What's your name?
I'm Tyler.
I'm Sarah, I'm from OT. Chelsea from OT.
Diana from PA.
Chris from OPEC.
Shelley from the social work.
I'm Katie from.
Yeah, I already know that.
So I guess since it's such a small group, maybe we could just throw out some things that came out of this session, this, what Mike taught us and talking about the individual cases. Who'd like to start?
Well, I think you and I are both my piece too. We have Tara, she's a 7-year-old twin. She has cerebral palsy. She has trouble performing bilateral fine motor tasks or different motor patterns for her extremities, so for example, like tying her shoes. Her mom works retail and relies on her own mother for childcare. Her mom is concerned with the gradual loss of motor control and her slow development as compared to her twin. As child mobility becomes more and more limited, childcare is becoming more difficult for her elderly mother who is not familiar with Tara's needs. And then we have some beautiful pictures here, which we spent a lot of time explaining. And how we would kind of explain this to Tara in a plain language kind of way.
Yeah, we spent a lot of time trying to figure them out, but I guess in the best plain language way, it shows that so basically the graph shows a normal child trying to perform a isometric task, and with her CP, it's showing that when she's doing the task, her other hand is also having a lot of muscle activation, and so she's having trouble with her bilateral motions like tying her shoes in the case study. So I guess in simple terms, we show her that, if she's having trouble with this is something that she's going to need to continue to have care for. And from a nursing standpoint, what jumps out at me is I might not necessarily be helping her directly with the kind of the PT and the motion, but she has a single mom, there's financial needs there, there's teaching for the mother, the grandmother, for maybe the child when she gets a little older, and teaching as much as she can gain now. And so we're kind of looking at the family and supporting and making sure that she's going to be able to have the care that she needs, because if her mother's not supporting her, she doesn't have any financial support, she's not going to progress.
I have like a million things to say, but I'll just say a few. So a few of them were, I was suggesting that, we explain this to her in a simple way, like maybe just saying that when you're completing activities, try to keep one hand still, working on like unilateral activities along with bilateral activities once she becomes able to kind of control the other hand, her impulse side. And then things we suggested were like just making sure that she really knows, I want to figure out what's meaningful to her, because I feel like, the example that I gave was I went to Colorado last summer. I went to Colorado last summer and participated in this camp for people with brain injuries. And I was paired up with my buddy. I was paired up with a 17-year-old girl, and I just made sure that she was able to meet all the needs of this camp, and the camp would do things like canoeing, ropes courses, stuff like that. So she was 17 years old. She was such a social girl. Like she just talked to me like I was her girlfriend. Like she was the cutest little thing ever. And she had these like writhing movements, and she was unable to feed herself. Like sometimes I had to feed her. Of course, she really wanted her to do it herself, but I tried weighted things, and she just still was not able to control her movements. But as soon as she had her phone with her, she was able to use the phone. She was scrolling through it. Like she was able to control her movements. So that was an example of just finding something that's really meaningful to her, because she really wanted to be social with everybody else and like connect with her friends, tell her friends what was going on. So just kind of an example of why I want to really figure out what's meaningful to Tara, so that way I can incorporate that into her therapy.
And also we were then talking about how doing motion to create a change in your brain just is so repetitive that, especially for a 7-year-old, but really for anybody trying to make it an interactive thing, and doing it in ways that can engage her like the phone is probably the best way that she's going to actually be able to really get over this.
And how these neuroplastic changes occur in the brain.
And I was thinking of the same thing from a neuroscience perspective, that as she feels success, that affects her mood, that affects her desire and purpose, and she builds on that stimulation every time. So
whether or not it was worth training.
We didn't think about that, yeah. That'd be a great way to do a repetitive thing, if it's something that.
Even
they
just
can
like
do
playing with
together.
her sister, you know,
Right.
just incorporating play. I think it'd be great to research, if you were the clinicians involved, to research twins, because, you know, they do talk for each other, they do help each other out with activities, get to mimic each other, so that's a great suggestion.
Yeah.
She could be her greatest ally in that. But also your point about the family, that, and your point about meaningfulness, that it has to, for the mother as well, that she has to see some progress and role and be very meaningful. What about the other cases? I know we're winding down on time.
Okay, well, our guy, he was 45 years old, underwent ACL reconstructive surgery in the right knee. He's a chauffeur with an engineering degree, and he's been diagnosed with onset diabetes. And then it just gave like a brief summary of the gait report. Showed decreased knee flexion during the first half of the stance phase, decreased peak knee extension moment, decreased quadricep muscle activity, and increased hamstring muscle activity. And then our questions were, you've received it, do you understand it, does the patient understand it, translate it in English. So honestly, I didn't really understand it. So Mike explained it to us.
It was a very crash course type thing.
Yeah.
Yeah, I would expect that.
Yeah, I imagine we'd be going around doing this.
If I had it, I might kind of talk about that. We might use the teach bag method, like have the patient explain to us, and then maybe try and fill in the gaps, like what this means to them. But basically, Mike explained that you're going to have atrophy of your quadricep and increase of your hamstring muscle. So there's more.
Most atrophy here, something stays the same,
Right.
or the activation increases. It's not necessarily this one's growing bigger.
Okay, but it stays the same, and this one's
Atrophy.
okay. So there's more contraction. Okay. And then we talked about how it's going to impact his life as a chauffeur. You need your right leg to be able to drive. Also kind of talked about with the onset of diabetes, peripheral neuropathy, being able to feel the pedals. He's going to need knee flexion, knee extension to be able to control the car. Also getting in and out of the car. Loading bags, opening doors. That kind of thing. So that's kind of how we discussed it.
Oh, they did a great job.
Okay.
But you had some great, you know, I asked, well, how about OT really utilize this kind of emotion lab and the kind of analysis you get? And you had a wonderful response to that.
I said that we initially, when we were sitting here, we initially discussed that we'd use it for research. Instead of immediately in the clinic, just deciding on backing up evidence for our different exercises and the treatment and interventions that we do, and then getting the results and then bringing it back to the clinic and saying, this is why we do this is why it works. And then eventually imposing that on the insurance company and saying, this works, and anyway, give me money.
You know, it's interesting, when I talked to the OT faculty last semester, one of the possible studies that they thought about was intentional movement versus non-intentional. I think I'm using those terms correctly. And it gets back to the phone thing, that, you know, if you're doing just some repetitive thing, and it gets back to what you're saying too about engagement. If the person's just doing some repetitive exercise, is there a different way that their muscles are activated than if they're doing something that is meaningful to them? And that's something that you could measure, you know, and it would be interesting to see if they're not engaged, that is going to influence.
I think it would be the difference between like lifting weights as opposed to maybe putting weighted cups away. in the
Exactly,
shower or
right,
something.
right.
Video games or something, and if there's a fine, video games versus just having them run through those actions.
Yeah.
Right.
And seeing how they do the video.
Well, they use the Wii a lot, you know, we have.
Rehabilitation.
Yeah, rehabilitation. I'm sure they are in OT as well, yeah.
We'll show balance and stuff, I think.
Yeah.
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 Well, actually, I mean, Louise, nothing really simple for us, really. So, yes?
But the Wii's more fun.
Yeah, that's a lot more fun.
You could probably, could you put the Wii on the force plate? Would that?
Yeah.
Or dance with I'm dating myself now.
Yeah.
But that's okay. But, you know, when you look at change theory and you look at motivational interviewing, I think you've all been exposed to motivational interviewing. It's got it. Yeah. There you go, yeah. You know, people have to be motivated for their own healing, you know? And so I love these ideas of just meaningful and purposeful activity. Also, the difference between, you know, often you get treatment modalities that are the same for everybody, you know, and so what might motivate me to, you know, move those muscles that are painful or try to get control of a tremor or whatever is going to be different than what motivates you, right? So getting this information is just,
I find it interesting that your young lady sometimes needed help to eat.
yeah.
Because if it was me,
She was
that would
also-
be my motivator, and I wouldn't care about the cell phone thing.
But I think
But
that
if
she
that's
was like a learned non-use from home too. I think that her parents at home kind of would do this for her, and because if she did it herself, one, there'd be food everywhere. Two, it would take a really long time. If it was me, I would do an entire therapy session. But that's just me. It was really hard because we did have time constraints, so I did have to feed her sometimes, just because, you know, we only had half an hour to eat before we had to go out and do another activity or whatever it may be. Sometimes I would spend a little extra time late or whatever it was, just because I wanted her to do it on her own. I think it's just a whole thing.
So nobody helped her with her cell phone?
No.
So she had.
I had to get her cell phone for her.
The people helped her.
But when I gave it to her, I set it on a pillow on her lap and she did all of
That's
it.
interesting.
There is such a rich vein there, because not only for people who may be compromised in other ways, but just for everyday life. What do you pay more attention to? Your dog or your phone? Your spouse or your phone? Your The thing about the phones is they're so ubiquitous,
Yeah.
and you're gonna start to see incredible repetitive motion injuries. Already it has happened. Well, yeah, but in terms of trying to get his attention off it, you know.
What do you tell her mother when camp is over?
What did I tell her?
What do you tell her mom about? Did you say anything about feeding her?
Oh yeah, I wanted to know because I met my buddy, I didn't know exactly what her ability was beforehand, so I kind of had to figure it out for myself. So I'd be like, here's your shirt, put it on. But she would pick it up and then couldn't really, her movements wouldn't do it, so I realized I had to help her a lot. I realized how dependent she was. But then at home, like I asked her mom when she got there, I was like, tell me, how do you transfer her at home? How do you do all this stuff? Because I just had to figure it out. But her mom does feed her sometimes and she changes her and she's very, very dependent, so I was very shocked.
I think, you know, the experience of having only half hour for lunch at camp gives you a sense of what the mom's dealing with all the time
And she
too.
has
Like
3 other kids.
she's got a whole life.
Right.
You know, she's got to choose between, let me get her out socializing with her friends. I got to get her to, you know, it's so hard.
Yeah.
But then to bring that to her attention and not make the mom feel guilty that, whoa, you know, I'm here, I thought I was doing something to help her, but
Yeah.
really, it wasn't.
and that's that would be a partnership between OT and social work. And
Yeah.
assistance, because that's the kind of work you can do beautifully with someone working with a child, someone working with a family. Because it, you know, her disability exists within a context.
Yeah.
Was this a congenital
Yes.
issue?
Yes.
So she didn't have an accident?
Yeah. That was because it's for people with traumatic brain injuries, who require their brain injuries, but they had an exception for this.
Interesting.
And she was also 17. This is a great learning opportunity, and I would highly suggest it. It's in Colorado. It's called the Breckenridge Outdoor Education Center, or the BOEC. If you just Google BOEC.org. It's free to go. Like you just have to pay for airfare. If you're a volunteer, they'll house you. They'll feed you. They'll do everything. It's a really wonderful program. I wish I could do it again, but airfare is.
Is it the whole summer or?
It's just a week. They have a bunch of different camps and programs. They have Women of Warrior. They have veterans with family supports too. Like they have the entire families come. It's really wonderful. Yeah.
We're just looking at each other because we're like,
We're like always on the same wavelength.
And they would love you for being there. They're so great.
we're thinking. Thinking. Actually, my
There's something
son,
coming up this summer too.
my son has done some volunteer work there and has done with people who have physical needs. We probably need to wind this down. You guys have been really amazing.
Thank you.
Thank you
Today.
so much. Thank you. And Mike, thank you. This was wonderful. You inspired this session and it was great.
Spread it around.
Now you're gonna have too many referrals to watch.
I don't know
There's
if
no
there is
such
such
thing.
thing.
Oh, there is. I can tell you there is.
We'll hire another person.
If you get someone in here who's had a stroke or something.
Yeah,
That would
there's
be really
lots of
cool.
stuff on that as well.
You guys do case studies? Case study?
Well, I'm trying to develop an advanced K course, so it would be case studies.
Next fall, with the incoming graduate students, we're going to try to use the mobility coding lab as a place for interprofessional conversations. Teams will cycle through, teams of maybe 30 each will cycle through and have a demonstration and discuss it.
Yeah, do a here today on a much more detail.
Is there like a full description of exactly what this like motion analysis is? 'Cause I'm writing a paper on this, so I don't want to be like, I don't want to use the wrong